Yeah, so welcome everybody back to Val-You Based Care. I'm always really excited about all my episodes and all my guests, but definitely love having Dr. Noelle LoConte. She brings me back to the days of University of Wisconsin in Madison, and just a really awesome cancer doctor. So thank you, Noelle, for coming.
Thanks for inviting me. It's exciting.
Yeah, I really love somewhat selfishly doing these just to reminisce about the good times.
Yeah.
So I really enjoyed that relationship that we have, especially as a trainee. I think it's very important to have someone who goes like, "Oh, I'm gonna like spend time believing in you and investing in
Mm.
you."
Mm-hmm.
So I remember how you would actually not only treat me as someone who's training in a profession, but also you treated me out to lunch, or a few of us, you would take us to have a little lunch. And I just thought that was really special. It's
Mm.
not common. I don't remember having a lot of those kind of moments. And it's really a very simple thing to do, but very heartfelt. So I wanted to appreciate you just for that mentorship
Thank you.
and recognize, because I think more of that, it's easy to feel like anytime I've tried to teach or mentor, to feel like, oh, that's such a small thing, but it
Mm-hmm.
actually really translates.
Yeah.
Yeah.
We all have to eat, right?
That
Food
part's
is love.
yeah, yeah. And so yeah, I wanted to ask you how things are going for you. Just remembering about how much you spent time with trainees.
Hmm.
Um, the style that you have is very unique because I feel like you're just authentic and personable. Everyone has their own way of doing it, but I
Right.
very much enjoyed connecting with you. So yeah, how is it going for you?
Yeah. Um, yeah. So I'm in academic medicine. It's a bit of a challenging time just with uncertain NIH funding and, you know, anti-vaxxers and the whole thing. But setting that aside, I think, things are stable and we're doing what we need to do. And I've got grants going in and taking care of patients and keeping all the balls in the air like you need to do in academic medicine. But I mean, it's the last year's been a little tough just from not really knowing what one week is going to look like from like legal stuff and policy stuff, but making it through.
Sure. Yeah, and I know you have a lab that's more about health policy, so I would imagine that probably was even harder. I mean, everybody face some grant issues, but it's not like a basic science lab, so that probably really
Right.
affected your trainees too, like your postdocs.
Yeah, it's a scary time for sure. I mean, we're weathering it. Um, NIH funding and NCI funding actually came out favorably in the end, so that was good. But Um, yeah, it's a lot when you don't know if you can pay your people. So hoping for more sort of steady ground, I guess, moving forward.
Mhm. Yeah, I would imagine you probably have a lot of that leadership through the uncertainty, where you have trainees and mentees are probably coming to you asking these really tough questions like, what should I be doing or
Mm-hmm.
thinking?
Mm-hmm.
And there's something very important about knowing that the climate is this is a tough season. It's like a winter season. Things
Mm-hmm.
are not like they always seem to be in the past. It feels very unexpected, and guiding people through that with transparency, that can be very hard. There's a lot of very intelligent professional people who start to shrink in that kind of a
Mm-hmm.
setting, but I can see
Mm-hmm.
how you probably had people coming to you and then you just sat down and had those conversations and didn't shy away.
Yeah, you have to acknowledge what you know and what you don't know and not try to overreact too much. Like just, you know, react when you know something for sure, but let's not panic, I guess. Let's panic when we know we need to panic. Um, I think COVID taught us that too, that we need to lean into some of the uncertainty and just do the best we can with the information we have.
Yeah, and I think you also are very good at not over promising and
Mhm.
sugarcoating and then
Uh-huh.
feeling like that's just going to set people up for more erosion of trust when they feel like that they're just being told something to almost kind of like silence them for the meantime.
Yeah,
So,
exactly. Right.
yeah,
Yeah, being honest, but not overpromising. Mhm.
right. Yeah, yeah. And I feel like you have that overall conviction just in general. You have just the way that you do things is very like direct. You have a way, you have an informed opinion. And so I was curious if there are specific aspects about your lab work that you feel like I know you mentioned vaccines, and I
Uh-huh.
think that it's very important to lean into these kind of conversations because it may not be what is often like our leaders want us to be necessarily talking about, but I think
Mhm.
some of us want to hear how should we be thinking about and having conversations and talking about these things if we get triggered in the clinic and we're eh, meeting with someone and then we get that moment of, oh, well, I don't want to do it because of XYZ reason. I think being able to be prepared for a
Mm.
conversation like that, as opposed to saying, we're just not gonna worry about it or go there, it's not correct. But I am very curious about how you think about running that aspect of your lab, but that public policy lens that you bring, and how
Mhm.
we should be having these very authentic, open conversations.
Yeah, I think in the clinic it's a little different. I think my best advice is to um, treat every patient with great respect. I don't think less of people if they make different choices than I make, but I want to ensure that they feel all their questions have been answered and that I have done my due diligence in giving them my understanding of the scientific literature and my rationale. And I think authentically being curious about why they're saying no to something that I feel like, I would give my children or I do myself, like help me understand where you're coming from. And I think continuing to show up for those patients, I think it comes up a lot for us with alternative medicine, which I would never support or endorse for an oncologic treatment, but you and I know there's lots of patients that do it. And then, if anything, there's more now than ever before in my practice. I've been an oncologist for about 20 years. Um, I think what I say is I can't support that. I can't prescribe that. I can absolutely recommend against doing that as the only way that you're treating your cancer, but I am willing to follow your disease and prove to you that it's not working. Um, for some patients, they leave and they never come back, but I have a fair number that appreciate the partnership and they keep coming back. And eventually we make our way to conventional treatment. And, you hope at that point it's not too late. And I think generally patients appreciate an open dialogue. Um, I think it also helps that I grew up in a split family. My father was Republican, my mother is a Democrat, and you just had to figure out those spaces pretty early on. I grew up in a real blue collar community and now I live in a very liberal community. I feel like being in that middle is really where I do it best. As far as my research goes, I don't, you have to be cautious and not ask for anticipatory permission. You don't want to give in too quickly, but you want to be very smart about it and listen and again treat the people that are changing the rules or wanting new rules with respect and really try to form an understanding of where they're coming from. Try to meet in the middle. My work is largely in disparities work, which kind of gets thrown under with this DEI or anti-DEI stuff, but disparities is just the existence of a difference. And all oncologists believe all patients should have equal odds of outcomes, right? So I try to spend a lot of time explaining to people disparities research is not DEI. They're different things, and we can't just like have these buzzwords and throw certain words, under the rug. So it takes a lot of time. It takes a lot of patience and calm and prepping your conversation and having, facts at the ready if you need them. So it can be very, very time consuming. But I think pays dividends in the long run.
Yeah. Yeah. And also in terms of disparities, because I was thinking about like physician shortages and how we're probably going to see if there's not interest in an attempt to watch the shortages, uh, there's probably gonna be worsening disparities because I would
Right.
imagine providers are gonna go where they feel treated better and lifestyles better, and
Right.
then that's gonna widen the care gaps.
Yeah, most of disparities has come down to just access to quality care. I mean, if there was like one thing you could fix, that would be it. It's not, it's that simple. Is that a whole group of population can only access poor quality care. Um, we spend a lot of time thinking about smoking and, income and so on and so forth, but that's really around the edges. The bulk of it is just access to high quality care and guideline concordant care. I sit on the NCCN guidelines, and it's shocking to me when people come in and they haven't gotten like the most basic guideline concordant care, but that would be the place to start.
Yeah, yeah. It even takes me into other aspects, even beyond oncology. Like I think of even I wasn't really around professionally in the times of HIV, but just like thinking about how a lot of where you see unhealthiness, you see the lack of access or the poverty or the just unfairness, the way we treat people unfairly. There's some sense of power is not even and somewhat that was designed or left to be that way. So I think a lot of healthcare, when we get really analytical about it and probably in a very uncomfortable way, is revealing where our injustices are in society. Yeah. And so I think of being an oncologist, the more that I've evolved, I'm in community care, and the more I feel like uh, before as a trainee, it's very much learning the guidelines and wanting to execute it really well. But now feeling like there's so much more to really be done because even if I executed the guideline really well, but then I feel like, well, actually, this could have been prevented because this person didn't have the education or the resources that could have saved so many things, their life, their whole family's life. And that really brings all of society down when we have individuals that we're somewhat turning a blind eye to and just saying that that's just the fact of life, or we create stories about who's working hard or deserving and who's not. Yeah. I think I see that with our patients too, manifesting in these, trying to be careful about misinformation and them coming in with a little more of that distrust or erosion of trust is because I think they're probably feeling in a global sense, maybe individuals as well, but just feeling like who's really there trying to stick up for me? Like we say there's a duty to take care of patients. We say we use this word like fiduciary role. We use all these words, but I think people are starting to feel like, well, who's actually owning that? Yeah. And I think having guests like yourself where we can talk about this because usually when we're walking around in a university hallway or in the clinic, it's there's almost this air of this is not the conversations that you have. But I think in podcasts where people are trying to get to know who are the doctors that I can really go trust and who will take care of me, what's the kind of work out there, there's a little bit more safety to be able to start talking about topics like this. Yeah.
Comes down to
Down to
humanity,
humanity. Yeah.
seeing our
Seeing our
humanity
humanity.
in each other and in our patients and in their families and taking care of each other. I couldn't tell you, I mean, when I first started my practice, I wouldn't even know my patients' politics. It would never come up. It was totally not relevant. I didn't need to know. I didn't want to know. And likewise, they never knew mine either. And I think COVID like ripped that wide open with masking and stuff like that. And I kind of yearn for the days where I didn't know. Um, and that speaks to like just this kind of polarization that we're seeing. And it's not just, red versus blue. It's like evil versus, morally correct. It's just like the choice is so stark in some people's minds. And so how do we come together around a shared understanding of what's fair and just for everybody, for America? Um, it's challenging. It's really, it's really, really, really challenging. But I mean, it's it's hard to see in the clinic all the time now, you know.
Yeah, it seems certainly very fear-based. I think
Mhm.
it all comes down to being afraid. And usually the folks who, when they're in more of like they're being curious, like genuinely curious, or they're showing gratitude,
Mhm.
they're not really in that same space. So when they're talking in a way that is feeding into that polarizing energy of, like you're saying, that splitting of good and bad, and that there's a hero and a villain.
Mhm.
I think it's that zero sum feeling of it's scarce and we have to fight, and it's almost like the dog eat dog, and one person is stupid to
Right.
yield over to another. It really
Right.
all comes down to being afraid, because the other way to think about things is, what if the world were actually, there's plenty for everybody, but we're fighting, uh, and we're not opening up to how actually there's enough. And maybe not, it's that also is maybe too extreme and simplified too, and maybe it's more in the middle, like some things we have to treat as scarce and some things are a little bit more abundant. But yeah, being able to help people get out of that feeling always afraid.
Mhm.
I think what's really interesting about spending time in clinic, what I've noticed, and I'm probably a little bit different out in the community, is I spend a ton of time with patients just listening to more their life things, like you said, like their views.
Mm.
And I feel like I spend less time getting to actually do medicine, but it's almost more therapeutic to them. They feel like
Mhm.
it made more sense that I listened to their view than compare, like, should they do surgery versus radiation, pros versus cons.
Mhm.
Um, and so I'm starting to change a little bit of how I communicate, realizing that what patients need is a little bit more getting that fear addressed first. Whereas I used to feel like I could just sit down and answer questions. Now it's more like, let's get the elephant out of the room first.
Yeah, I don't think being an expert holds the same weight now that it used to hold. I don't think our education or our training people go, so what? I want to know you and trust you and have a relationship with you more than like, oh, you went to such and such med school and did training, here and there. Whether that's kind of practicing in the era of Google and people have ready access to really unlimited websites and medical research, or whether that's just, kind of the state we're seeing with like higher ed sort of becoming less of a expectation for every American child and kind of this swing back to more blue collar jobs. I don't know. But yeah, I mean, gone are the days that people will take on face value what I have to say just because I have an MD after my name.
Yeah, and I know this is a very tough topic, but also at the same time, I think a lot of healthcare providers could probably relate to how sometimes they even experience more of that hostile feeling from patients.
Mhm.
And and there's even some data on how there's increasing acceptability for, like globally, for if something's not right, then the activism could include some hostility.
Mhm.
And I think healthcare providers are not immune to that people will come in, and because they're so afraid, but they also think our role is to take a lot of their fear in whatever way it comes,
Mhm.
that we do face things like threats and violence and
Yes.
uh, like you said, being an MD doesn't protect anything about our who we are to them.
No.
And I wanted to make sure that we spend some time touching upon this, because I
Mhm.
think there are providers who, when they face it, they actually feel very ashamed, like they did something wrong.
Yes.
Like if they were a better doctor, that wouldn't have happened. That
Yes.
a good doctor leader is supposed to command the room. But
Yes.
I think that's all very unhealthy narrative compared to the reality.
Right.
Yeah.
Yeah, I mean, for your podcast listeners, so I published in the Journal of Clinical Oncology one of the narrative pieces, and it was called "I Want to Kill You." And it was a piece I wrote about a patient that threatened to kill me in a very credible way. Um, and it's partially about that. As oncologists, I think, or at least I thought, like, oh, that happens in the ER and psych. That doesn't really happen in onc. Um, so partially to sort of just shine some light on that, but also it was the organizational response to that, and kind of what went well and what didn't go well, and what I think all oncologists, especially leaders in oncology, should know. Because I agree with you, incivility in medicine is becoming more common, and we should all be equipped to deal with it, because I don't think that it's a small number of people. I think it's going to be most of us at some point if you practice long enough. And so normalizing that it's an expectation. But I will say, after I published that piece and I did the podcast for it with Art of Oncology, I had so many oncologists reach out to me. And it was so, well, first of all, it was sad, because I'm sad that they had to deal with that. But it was so therapeutic for me to feel like I am not alone. I'm not alone. I'm not the only one. And I've worked with oncologists now that, like, are facing the same struggles, that they're not, being believed, or that they feel unsafe, and what can they do? Um, so it's been both a good and a bad. I mean, I wish it never happened, of course, but it was interesting, because I'm not really like a writer. I journaled in high school, but not really since. But I felt absolutely compelled to write that piece. I could not stop thinking about it. It wrote itself in a day. Um, like, I had to get it out there. Um, and I'm glad I did. But yeah, I think, that was what, 6 years ago now that happened. So yeah, if anything, it's more now. And I do feel better prepared. But at that time, I was like, I need to get right back to work. I can't believe it, but I went through the rest of my clinic day. I didn't leave. I was in full blown, like, trauma mode, seeing patients. I mean, bonkers, right? Like, I should have left. But not only did I not leave, I thought, well, I'll just go to work the next day. And then I couldn't. I couldn't. Um, it's, so yeah, it was, I have four, like, human children, and then I birthed that piece. So I am happy to talk about incivility in medicine and threats against physicians, because I think we bury it too often. But um, it's been really heartwarming to see all the different types of people that have faced the same, including absolute giants in oncology who I never would have thought had to face that, and they did. I just think we don't talk about it because we're ashamed, or we're trained to, like, not, you just got to keep going, show up to work sick, show up to work traumatized, just keep moving, moving, moving. And I do feel like that's finally changing. But man, that was the culture in medicine for a long time.
Yeah. I think it's really important to the part that you mentioned about the institutional and leadership response,
Mm-hmm.
because I think of how, yeah, there's the original very traumatizing experience, and then it almost feels the second time, hard to say, more severe or worse, but you don't really expect to uh, go through something and then have your colleagues or the people that you trust
Right.
respond in a way where you're like, now I feel like I can't ever, say anything ever again.
Right.
And so I really wonder about how do we help ourselves with learning through these and then training our leadership and training our institutions to have that, for lack of a better word, I use the word empathy a lot, but really, it makes me wonder, did they go through something and they didn't want to deal
Mm.
with it? So this is
Mm.
really them putting up a shield because that's not been dealt with on their end either.
Right.
So I
Yeah, or have they never really conceived of it because it's never happened to them?
and there is that too. If it hasn't happened, that goes to that curiosity of like sitting down and wondering, well, if it happened to someone, what does that really mean? And not just how do they think it should be.
Right. Yeah, I think leadership should have an understanding of what are like red flag crisis situations and have an immediate plan for the short-term management of those situations. So, patient with a gun, patient who threatens the provider, you know, these kind of like major, major, major problems. Um, I'm sure there's, physician having inappropriate relationships with a patient. Like, there's probably only 5 or 6, but like I need you to have in your brainstem, like, here's how we manage this for the first week while I talk to other people and figure out, the longer term game plan. But what happened to me was it was just like, oh, that's too bad. Like, I'm so sorry. Or let me look into it. And then no response. And meanwhile, I'm not sleeping. I'm terrified. I'm having panic attacks in clinic. Like you said, it just kind of makes it worse. Makes a terrible situation worse, if that's even possible. But yeah, so I mean, I think the call that I made in that piece and on the ASCO podcast was like, please, please have a plan. And for those of us, worker bees who are not in leadership, know your rights and know um, you're not alone. And here's how to get help. And um, I think reach out to people that you trust who will be your advocates and can speak for you when you can't speak for yourself. That's why I'm like loud and proud about that. I'm also loud and proud about being reported to my state licensing board because at the time it happened, Kim, I felt so ashamed. So ashamed because I had never known a single physician who had ever been reported. And then come to find out, like half my division had been reported, but no one talked about it. If I had just known I wasn't alone and like I could talk to people that had been through it, like what happens? Who do I talk to? What's likely to happen? What's the worst case scenario? What's the best case? I'm somebody where I like a lot of information. And so us, creating privacy and scarcity around these conversations just can make it even harder.
Yeah, yeah. I mean, I think having that as part of our training of
Right.
when you become a doctor, you could get threatened and you could get sued, and
Mhm.
all of these things happen. And here's the real stats, and here's real people who are open to talk about it.
Mhm.
And feeling like then when we go out in the world and we do things, then we're not so uh, incapacitated by shame. And I think part of this comes from a sense of generosity. Like, if we could go back and redo some of these things, like if you went and told your leadership, oh, someone just told me they're going to kill me, and you got the response of, oh my goodness, go home, you get like a paid week off,
Mhm.
call me every day and tell me what you
Mhm.
need. Do you
Mhm.
need me to send you some food? like
Mhm.
like just
Mhm.
get treated as if
Mhm.
what happened was really, really important.
Yep.
Like, how is that so hard? to be generous, to start out that way,
Yep.
as opposed to react after the fallout of everything. Now you're tired, you're having panic attacks. Now they have to escalate effort. Why not just start out full blown with that very compassionate, like, here, tell me what you need. Let's make that for you. I apologize. We didn't think about it before. Now let's think about it in the future, because that sounds like that's really important to you. I just sometimes it makes me go a little bit like cuckoo when I go,
Mm-hmm.
how come that this is so, has to be so hard? Why is
Think
it now we're talking about it now, and we didn't want it to be the initial strategy? We're now reacting.
right,
And I think a lot of it is, it's hard to be generous with someone else when in medical culture, we're not generous with ourselves. We don't
right,
tell ourselves we can go home and we won't get judged.
right,
And kindness and softness with ourselves is actually a sign of strength.
right.
And I think learning that through, as you have, where I feel like you very much reflect and take on these very challenging times and you
Mm-hmm.
want to share.
Mm-hmm.
And that's not something that we find very often in medical culture.
Mm-hmm.
Yeah, like I know we've talked about, for female physicians, we run into problems with things like fertility
Right,
and loss of children through
right.
training. Like that's something that people don't really feel like they want to talk about. And I don't really understand, for women when they, or families in general, when we go through medical school, I can understand people are afraid of those conversations, but they're people who want to know. So why aren't we having those as part of our training?
Yeah.
So yeah, those are the things that I know it makes me kind of weird, probably like dark. Look, you're gothic. You're gothic oncologist, but like,
I prefer punk, but okay.
it's just not like steampunk, right? Just like
No, no. Yeah. Rock and roll punk. Yeah. Black is my favorite color.
I'll admit I like gold.
Okay.
The black and gold match very well, though.
Mhm. It's true. It's true. I think, it's two factors. It's that you and I practice in a field that until recently was really male dominated, and men don't talk about miscarriage because I don't know that they can really have that conversation most of the time. And just the word miscarry, I mean, that all the blame's on the woman. You didn't carry the baby. You know what I mean? So we didn't have a lot of male or female partners, so there weren't a lot of female conversations. I mean, I can remember the first time somebody talked to me about handbags, which is like my secret hobby. I was like so excited. I'm like, you want to talk about handbags? Let's go. Um, I don't have to talk about, football. Great. Um, so there's, yeah, not enough women. And then I just think in medicine, I mean, we teach you you serve the patient, and unless you're dying, you need to keep serving, the need is great. Um, and I think health systems take advantage of that strong, strong desire to serve people, and hardcore reliability, and it can be used not harming us is too strong, but to take advantage of us. Um, and you need people to model for you what it looks like to not do that, right? And ideally, it's people that are advanced in their career enough to, when you're an assistant professor or just starting your practice, like you don't feel comfortable being the example of that. So, yeah.
Yeah, yeah, it's very like, I look at it like whoever is at the top of the hierarchy of the food chain, so to speak.
Hmm.
No, it says a lot about their character when they're willing to help someone who's so close to where they are,
Yep.
because that person could take their job or
Yep.
outshine them,
Yep.
but they're still willing to help them. And I don't see it often, but when I see it, remarkable. And so I see people in adjacent roles when they help each other out. I gravitate toward those people.
Right.
I felt like, working with you, you're someone like that. And it was something that gave me a lot of power. Like
Mhm.
I feel like being able to be a leader, there's all sorts of names for leaders. I hear different like servant leader,
Mhm.
like heart leader. I actually really like the heart leader one. But I felt like I never even thought of myself in these words.
Hmm.
But as I worked with you, I thought, well, maybe I could start
Mhm.
thinking if I had a leader identity, what kind would I be? And because you role modeled and you were like, no, this is okay.
Mhm.
And yeah, there are people who may not agree or not comfortable, but
Mhm.
when you held your space the way you did, it showed me that that was something that I could be doing. And really, actually, it's a sign of uh, like a very beautiful sign of true career mobilization. Like you're really truly growing when you're starting to be looked as a role model to someone. It's not
Mhm.
even, it feels like that assistant professor, associate professor, full professor, but it's really not that. It's more like more trainees wanted to come and work with you.
Mhm.
It's more of that, like I can feel like a healthier person because I get to work with Dr. LoConte. So that to me, that what we call like non-promotable work is the very much needed work. Very much wish that we would all talk about that so much more
Right.
and give it the karmic credit that is due.
Right.
Right. Yeah. So I you
It's
very much
especially hard in academics though, where it's like not on your promotion packet. I mean, your
yeah.
teaching evaluations, I guess, are, but yeah, it's not the commodity. It's grants, publications.
Yeah, which is it says a lot that you still want to do those things. It still feeds you. And it's been 6 years since I've worked with you and I've chased you down. Come on a podcast. I didn't know you had a handbag fetish.
I do,
I would
yeah.
have, showed
Mhm.
some of my. It's not like I'm very good at it, to be honest. I'm acting like I'm a lot cooler than I am, but I would have been able to. We
You
could have
got
talked
game.
like football handbags. We could have still been cool that way.
Well, ASCO's in Chicago. We can go go check out Michigan Avenue. Go to Ferragamo.
You're going to
Yeah.
ASCO this year, you think? Yeah, I'll be
Yep.
at ASCO too. So
Yeah. Awesome.
yeah,
That'd be
that'll be
great.
really amazing.
Mhm.
Yeah, which by the way, I know this is going to sound even weirder, like of all the things we've talked about already. I know that you also talk a lot about prevention of
Mhm.
cancers and
Mhm.
things like I think I've seen you talk about the alcohol.
Yep.
And so there's and I find it really interesting. I know it's not everybody's cup of tea or a cup of alcohol, but like to say that should oncologists be at a conference and doing like, let's drink, yeah, let's have this. It's very
Right.
interesting for that. And I remember reading that and you were talking about this very much about if we're really going to align actions and words, is that what we want to be doing? Especially, I
Yeah.
think, I'm trying to remember who had said it. Maybe it was the WHO. Like, even one drop is not okay. It's not, if that red wine study is not completely accurate. So,
Mhm.
and I have a lot of that respect of that consistency. I'll admit, I probably look like my actions and words don't always match up very well. So I really appreciate that you brought that lens because that's not easy to say something like that.
It's not very popular. Yeah, they call me Dr. Buzzkill for good reason, but um I mean it's a carcinogen. I just think as oncologists like how how can we not model good behavior? Um It's a known carcinogen. I don't know. It'd be like holding a cancer event at like a cigar bar or something. Like everybody would be like, "What?" But for whatever reason, we think alcohol is socially normed so much that we don't even need to think about the fact that it's, 5% of cancers. Um, yeah, I did a piece with Shalon Begg right before ASCO in the ASCO Daily News about like, hey, ASCO, should we really be having alcohol at our premier oncology event? Like, is that really necessary? And the pushback I always get is, you need alcohol for philanthropy, which I guess I'm not here to argue if that's true or not true, but we could do certain things like drink tickets rather than open bar, right? Or we could have extremely appealing non-alcoholic options rather than just like here you can have a can of Diet Coke or something. We're adults, like we like adult beverages, and that doesn't just mean alcohol. You can have really sophisticated coffees and teas and mocktails and other things that appeal to an adult palate. Um, but yeah, after my alcohol policy piece came out in the JCO, a very high level leader in ASCO, not a staff person, but like an elected person, came up and he's like, I don't like your paper. I like to have a drink every night. I'm an oncologist. And I was like, okay. I mean, it was such a odd thing. And I was at that point in my career where like I still had kind of, um, I was like fangirling for these people that have very, very advanced careers in oncology and had brought, new drugs to market and so forth. But it was this moment where I was like, okay, this is where like the practice of oncology and like social norms sort of meet. Um, but I see every day, I'm a GI oncologist, so I see what colorectal cancer does, what esophageal cancer does, what liver cancer does to families and to patients every day. And I think I can't not stand up and say like, hello, like, can we please prevent these cancers? They're really terrible things. So yeah, I mean, I think ultimately, this conversation is making me think about the fact that it really comes down to like knowing authentically who you are and not wavering from that. Not that we can't change. I certainly have changed as I've gotten older, but like, what are your values and staying true to those and not modifying them.
Yeah, and I also think it's interesting how just because you're talking about your values, that someone else would feel threatened because you're not really saying anything about other people's values. You're just
No.
saying you're a medical oncologist and you don't want to promote alcohol because you think it's a carcinogen, but you're
Hmm.
not saying someone is less of an oncologist because they are.
No.
And that is a very like fine distinction that can threaten people very
Hmm.
easily.
Hmm.
But you're really very much just saying what you're owning up to,
Hmm.
and you're not really judging. Like just because someone else is going to get a drink, you weren't saying the oncologist can't have a drink. You definitely were. You were thinking like this is a conference and we're here, and you don't want to take part in that, and you're
Hmm.
hoping people might feel the same way, but they're not saying that they're bad people if they don't.
No. No.
And so I think that's also deserves reflection for people who do get triggered to go
Right.
like, how come I'm now feeling threatened because they didn't literally say something against me? And maybe it means it's not such a bad thing to think about what change would mean. It just is uncomfortable and unfamiliar.
Hmm.
But yeah, I struggle a lot with Diet Coke. Like me and Diet Coke go back and forth. Oh my goodness. Yeah,
Yeah.
but I very much I think there's something really interesting about how we do probably unconsciously compartmentalize and go like, "Oh, I'm a doctor, but I'm gonna drink 10 Diet Cokes. I'm sorry. Okay." Is this like a confession? Can I just,
Yeah. Yeah. Right.
you absolve me? Thank you.
I, I will absolve you. Yes.
But yeah, it is. an interesting examination to go like, well, do I really want to do this? Even if it's not a conference, just by myself,
Mhm.
I'm the only one who knows. Do
Mhm.
I really? And then it's not wrong to say, well, I'm just going to anyway. But then knowing, okay, so I'm kind of doing inconsistent things right now. So how am I gonna health wise be okay with that? How is that gonna leak into other things? Maybe I'll be okay and compartmentalize and that's okay. Maybe it won't. But
Right.
I think having that type of examination as part of our medical training is would be a really interesting exercise. Like
Yep.
because our patients hold us up that way, like it or not. Like I'll have patients say I saw my doctor out smoking and that affected them, or they get really frustrated when their weight becomes a topic, especially when their providers are not necessarily, immune to the weight problem themselves.
Right.
So there is a little bit of that, rightfully or wrongfully, uh, our actions motivate whether or not patients want to listen to us.
Right.
So yeah, I think it's an interesting. That would be very for trainees to have a class where only two people show up wanting to explore something like that. But
Yeah.
yeah.
I mean, I think you can also tap into that stuff though through faith communities or through other social organizations, book clubs, that kind of thing too, that um it's been very freeing to me to like have other outlets to think about my whole humanity. Um and then accept that I'm a flawed human and yeah, I do think medicine teaches you to be perfect and I think all that other stuff teaches you like none of us are perfect and so can be quite liberating.
Yeah, yeah, and I think a lot of being able to connect with patients, they really don't want perfect.
No.
Yeah, and so we're almost doing it, living in our own heads when we try to be super strong and make everything impervious.
Right.
Yeah, I think they want us to connect, soften up, just tell them how it is,
Right.
listen to them. We'll get it wrong, they'll get it wrong. We'll get hurt, they'll get hurt. Like
Mhm.
any other relationship. Yeah.
Right. Yep.
Yeah. Well, I feel like I always eat up everybody's time. So, because I'm like, oh, let's just chat. Like, it's fine, it's fine. But I did want to. I would like to end thinking about a compelling future, and so
Mm.
I noticed this just kind of accidentally with myself. I didn't even think about this, but I'm noticing I'm asking everybody what your thoughts are of helping the next generation. Like,
Mm.
what does leadership look like for them in terms of what they want to do to embody that and what to make that future so much better? What's your advice for
Yeah. In
the
medicine
young?
specifically, yeah.
Yeah.
Um, I think knowing yourself starting as a pre-med, um, doing the really difficult hard work of knowing who you are and what you stand on and carrying that through. It sounds so easy and superficial, and it is so very, very hard. Um, I'm a big fan of therapy, been in it for a long time, probably will never not be in it. I think deep insight is a wonderful thing. But then I think when you get to the point of being a high level leader, so many years into your career, there comes a point where you need to set aside your own personal career, whether that's research, whatever, and you're working for the physicians that you've hired or that report to you. You're working for that team. It's no longer about you and what papers you're going to get published and what grants you're going to get. And so not taking on leadership until you're really ready to take that kind of pivot. Um, I've served under leaders that tried to keep their own research program going in their own, first author publications and clinical trials while also supervising a huge division. And it doesn't go well. My best leaders have always been people that, you know, have high expectations for me and, you know, are very accountable and enforce things, but also on some level, work for me, right? They're there to make sure that I succeed and I have what I need and um I continue to grow and at the point that I am not continuing to grow, then we think about how to change things. So I think that would be my best advice is really be thoughtful and careful about leadership opportunities and really think about, am I ready for that? Am I what that role needs? I think a lot of us just say yes to everything we're offered. Serendipity is our main way that we grow our careers. And I think being really mindful about it is the best step. And that starts with knowing who you are and what you believe and what you stand for and staying true to that.
Yeah, that's such a deep, perfect answer. I don't think I've heard that yet. And I've actually, as the non-leader in dynamics, I've learned that through, getting hurt from people who say yes and they think they're being a leader and there's allowing me into a world that I'm not ready for because
Mm-hmm.
they're just thinking, let's advance, let's progress. This is achievement, this is significance. But you're talking about truly like growth, contribution, love, connection. And so I've actually,
Capacity too. Like, do
yeah,
you have the time to give to this role?
yeah, because you also, if you say yes, but then you're never there, or you
Mm-hmm.
give people 1 minute and cut them off,
Mm-hmm.
can really damage them. And
Yep.
and I've actually been that in those phases in my own life where I'm like, let me go like, keep on achieving and I'm gonna keep shooting forth and this leader says I should. And then my intuition's like, no, you're not ready, you're going to get hurt. And then I just keep going and I got hurt.
Yep.
And that was because I also didn't have the discipline, but also my leaders weren't really looking out for me. So
Right.
people can get really hurt when we're not thinking about it's not about like niceness or inclusion of yes to everything. It's like, am I really thinking about that person as if, what if I hurt them? Am I going to
Yeah.
sleep at night? Because I could do major damage. If I'm not ready, I should actually just let them go. Be like, I know this sounds harsh, but I don't think I'm really ready right now, and
Mm-hmm.
I just don't want to hurt you by saying yes, and I'm not ready.
Mm-hmm.
And that can be
Mm-hmm.
really hard because I probably have been in places where I'm like, I don't want to hear that. That sounds like it's not you, it's me. That sounds like so
Mm-hmm.
pathetic, but there is a lot of wisdom in slowing down. So I really appreciate you.
Yeah. No problem.
Yeah.
Likewise.
Well, I feel like this is the perfect way to end our episode today. And I just want to thank everybody again for coming to Val-You Based Care. I always feel so honored and I'm just having a ton of fun.